House Bill 2587. Chair recognizes Representative Olcott to explain the bill.
Thank you, Mr. Chairman, members. Thank you for the opportunity to lay out my filed version of 2587. I did want to let the committee know that I am working on a committee substitute. I've been in talks with members of Health and Human Services Commission as well as the Texas Hospital Association to tweak the bill. And I'll hopefully be having something back within the next couple of days. They're also going to be resource witnesses. But basically, this is a simple bill. It requires hospitals here in the state of Texas to report the amount of uncompensated care due to people in the country illegally. And it's actually something that we're already collecting. Health and Human Services Committee is already collecting that data. They got their first set of data back in March. But there are some differences, and it's my understanding that Health and Human Services Committee is actually interested in getting this in legislation because it makes them easier to set up some standard policies to actually help collect this information. For example, that it's going to be filed electronically instead of, they actually got some data on like pieces of paper. And so this is something that I'm looking forward to working with them with. But just to let you know some of the more details of the bill, and that is that once passed, the bill would require hospitals in their patient intake form to include a simple question inquiring on the immigration status of the individual seeking care. But importantly, it also includes a statement on that same form that reads that their health care service will not be affected by their answer. And there's another safeguard in there, and that is when the hospitals report the data to Health and Human Services, it does not contain and is not allowed to contain any personally identifiable material. And basically, it requires the hospital to report quarterly, and if passed, the first set of data will be required by January 1st, 2027, and that might be a little bit different than, that's actually the intent of the committee substitute. I forgot exactly the date in the bill itself, but anyway.
All right. Representative Jones.
So if you don't fill out the section on the form about your immigration status, are you denied care?
No, you're not.
And Health and Human Services is gonna keep the information, because you could actually be a citizen or hold a green card and not have money to pay.
That's correct. That's correct.
Why is the immigration status important?
Because we've had since 2005, we've had 181 small rural hospitals close, primarily due to uncompensated care. And I think it's important as legislators to understand there's probably multiple, and I know there's multiple reasons for that. And the goal of this is simply to know what percentage of that uncompensated care are due to people that are here illegally. I think that helps us make informed decisions on future legislation.
But if it doesn't matter what your immigration status is because you're going to get service, I still don't know why that's relevant.
That's probably a good reason why you shouldn't object to the bill.
I think reasonable minds can differ on that.
Okay. I did want to point out that in the filed version of this bill, I wanted to make sure that I get that on record. It's actually, the first set of data is due on November 1st, 2027.
Okay. Thank you. All right. We will reserve. Oh, I'm sorry.
Yes, and
Representative Simmons.
yes.
Yeah, thank you, Mr. Chairman. Thanks. So I'm looking at the report, and it says it won't have any cost or impact to the state, but what about the hospitals themselves, the administrative, but also the financial burdens caused by the implementation of this bill? How do hospitals actually fulfill it, and how much in time and money is this going to cost? But I guess more importantly, too, how does a hospital actually verify the immigration status of a patient? Just like Rep. Jones asked and said if they don't have to fill out the box. So then is there another additional step is the hospital going to take? Because they'll still receive the care. And if I just want to say no, I can say no or not check the box. So I guess I'm trying to understand how that even works.
Well, they are not required to, the hospitals are not required, either in my bill nor in the governor's executive order, are they required to verify. They're simply required to ask. And as far as costs go, this bill actually, I'm fortunate enough, there's probably not going to be a fiscal impact because it's already being done. And I think some of your other questions actually would be very relevant to ask the representatives from the Health and Human Services Committee, if they're still here. We had a great conversation yesterday, and like I said, they think the one advantage of having this put in statute and legislated that makes their job a little bit easier to implement what's already been done.
Thanks. I'll ask the
You're welcome.
witnesses.
Okay, thank you.
Thank you. And I reserve the right to close.
Thank you.
Thank you.
Okay, I'm going to go ahead and call the resource witness from Health and Human Service Commission, Victoria Grady, forward. Okay, you are Victoria Grady, testifying on behalf of the Health and Human Service Commission as a resource witness. You are neutral on the bill, is that correct?
Yes, sir.
Okay. Did anyone have questions for Health and Human Service? Representative Simmons, did you want to?
Yeah, just clarification on, I guess, what would this actually do if people don't have to fill out, like, what information are we actually gathering? And if there's an executive order already in place, why, I guess, is legislation needed to be passed if the hospitals are already doing this and have the power to do so?
Sure. So I'm Victoria Grady, and I'm the Director of Provider Finance, and my department is currently responsible for receiving all of the data that's being collected and compiling it for the purposes of complying with the executive order. We've had a lot of questions, I would say, from hospitals in the state, and one of the things that is currently the situation is we do not have any rulemaking around this executive order and the reporting, and so that means that there's not necessarily clarity for hospitals in terms of the definitions of who is required to report or things like that. The other thing is that we can't currently or we don't currently require them to only submit it to us electronically. So we've received some submissions from some hospitals by mail. And so we're retyping the numbers that they've sent us into our spreadsheets, and we'd really like to get it electronically.
And, okay, because I feel like I probably should ask the actual bill author my next question, but thank you.
Representative Schaffner.
Do you have any summary of the data you've collected so far?
As I mentioned, we've been getting some by old-fashioned mail, and so we're retyping, but we anticipate having data that we can release at the end of the week from the first round of reporting we received on March 1st.
Do you have any sort of guesstimates, or can you guess, or?
Guesstimates of
data.
which numbers?
Of the numbers of the data that's being supplied?
So the numbers are not yet final. We had over 600 hospitals to collect from, and they reported on 16 different data elements. We did have substantial compliance with the reporting requirement. I believe we had 558 hospitals that completed the reporting, and I can tell you that the number of visits was in the thousands, or the tens of thousands, and the costs were in millions. But we should be finalizing the data by the end of the week.
Would the end result be some sort of reimbursement from federal government, or what would you?
This information is purely informational.
Okay, thank you.
Okay, Representative Jones.
Do you have any concerns that asking people their immigration status would dissuade them from seeking treatment?
The executive order and this bill are both very clear that the question needs to be accompanied by a statement that answering would in no way impact their ability to access care.
So I understand that, right? But there is rounding up of undocumented people here. There are U.S. citizens being rounded up and being locked up, and they're U.S. citizens because they look a certain way, whatever that way is. So my concern is that, and let me go back, and even if you choose not to tell your immigration status, then people know you didn't tell it, and then they think maybe you're hiding it. So like for me, if I went to the doctor, I wouldn't fill it out because ain't nobody's business. I need for the doctor to pay attention to my health, not whether I'm a U.S. citizen. So I just think that it's taking the emphasis away from health care and putting it on other things that could put people in legal jeopardy or be subject to profiling. Is my concern.
Representative Collier.
Thank you, Mr. Chairman. Just looking at the way you're doing it now, and I guess in the bill, the way it's being proposed, is the intake form a private health care form that's not subject to disclosure? Like it's protected under the Healthcare Privacy Act, I guess?
At the patient level at the hospital, you mean?
Yes.
It should be subject to HIPAA.
Okay, HIPAA. So it's a HIPAA form, so if whatever response that you have is not to be shared with anyone, not even ICE.
I couldn't answer what the interplay between HIPAA and immigration authorities are. I'm not a lawyer. I'm a finance person.
Sure.
I'm sorry.
I just wanted, well, right now, you said that it doesn't impact your ability to get health care or medical care on the date of service. But does it mean that you won't share it with somebody? Like, can the hospital share it with another entity or agency, or is it protected? I'm just trying to figure out how that works, because while you're saying that under the order and this bill that it's not going to impact your ability to get care, could it impact your ability to be there afterwards, I guess? I don't know.
So I think you're asking about what the hospital's ability to use HIPAA-protected information and make disclosures, and I'm not.
Okay, you're not the right person to
attorney.
ask the question. Okay, you're just collecting it.
We're
They're
just getting
doing
the
it,
data.
and you're making sure that they're asking the question.
Yes, for purposes of providing us the report. Yes.
And you don't enforce HIPAA violations, or
My department does not. We're part of the finance team, and
Okay.
to the extent that there was a HIPAA violation, to the extent that there was a potential HIPAA violation, that would be handled via, depending on who made the violation, either as by our regulatory team as a licensing matter or by the appropriate law enforcement authorities to the extent that it was a criminal action.
but your agency has a separate department for that, for HIPAA violations?
So not specific to a HIPAA violation, but our regulatory team that does licensing does receive complaints, which could include HIPAA violations.
Okay, and so if there was a sharing of a HIPAA form and somebody complained that it was shared, it would go through your agency department, a department in your agency?
That is one place that the complaint could be made to, yes.
Okay, that's one of them. All right, thank you.
Representative Schaffner.
What actual information is collected?
We are collecting, so at the agency or at the hospital?
At the hospital, the hospital that's sharing with the agency, is it just numbers?
Yes, so
But there's no names attached?
correct. The hospitals are not reporting any individual information to us. They're reporting the number of inpatient discharges, the number of emergency department visits, both for persons who are not lawfully present and those who are reporting as U.S. citizens, as well as the costs associated with that care.
So basically just numbers?
Yes, no client level information.
Thank you.
Okay. All right. Thank you for your testimony. Thank you. Chair calls Crystal Gomez, Priscilla Lugo, Trudy Taylor Smith, and Heather De La Garza Barone. I have Crystal Gomez?
She's not here. She left.
Okay. Show Crystal Gomez registered neutral on the bill and not testifying. Have Priscilla Lugo. Okay, I show you testifying on behalf of yourself, and you are against House Bill 2587. Is that correct?
Yes, sir.
Okay, you may begin.
Good evening, Chair and members of the committee. Thank you for the opportunity to speak today about House Bill 2587. My name is Priscilla Lugo, and I'm an immigrant rights advocate and here to testify on behalf of myself and my sister, who is a doctor with a specialty in family medicine at a large academic institution here in Texas, who cannot be here today to testify on how GA46, the precursor to this bill, has harmed her patients. HB 2587 is a dangerous bill for victims of domestic violence and human trafficking. Research highlights that 28% of trafficked women saw a healthcare professional while still in captivity. These encounters represent critical opportunities for intervention that will be missed if the victim does not go to the hospital or see a provider out of fear of disclosing their immigration status. Texas should never be a place where an abused person cannot safely walk into a hospital and get the care and intervention they desperately need. This is the risk we take when we turn hospitals into sites of immigration enforcement or data collection in ways that fuel fear rather than healing. If people fear seeking emergency medical care out of fear that it could lead to a deportation or that their presence might trigger immigration scrutiny, then we are failing both the victim and our communities. As for my sister, she decided to go into family medicine because she recognizes the importance of preventative health measures and how taking care of issues early on through your primary care provider could prevent diseases from worsening due to lack of treatment and the critical role healthcare providers have in enhancing public safety. I will now share her testimony that she wished for me to share. I work at a county hospital in a large academic center, which means I see all types of patients: insured, uninsured, citizens, legal immigrants, and illegal immigrants. As a physician, their legal status does not change the type of care I provide, but this executive order has brought unnecessary stress to my patients. They express concern about coming to medical appointments or coming to emergency room at the hospital for fear of being reported and deported. Sorry.
Thank you, Ms. Lugo.
Mm-hmm.
The chair calls Trudy Taylor Smith. Is that correct? And you are with the Children's Defense Fund Texas and yourself, and you are against the bill. Is that correct?
That's correct.
You may
Thank you.
proceed.
Good evening, and thank you for this opportunity to testify. My name is Trudy Taylor Smith, and I'm the Senior Administrator of Policy and Advocacy for Children's Defense Fund Texas. And we are a nonprofit advocacy organization dedicated to building community so that young people grow up with dignity, hope, and joy. And we strongly oppose this bill because it would limit access to health care for children in immigrant and mixed status families, compromising their long-term well-being and the health of our state. While this bill does not require hospitals to report individual identifying information, it still runs the risk of endangering the health of countless Texas children by creating fear and confusion that discourage immigrant parents from seeking emergency medical care for themselves and their families. In 2023, similar legislation passed in Florida, creating widespread fear and reducing access to health services for immigrant patients, even though the Florida law, unlike HB 2587, explicitly states that disclosures of status will not result in a report to immigration authorities. Texas already has the nation's highest rate of uninsured children. 11.9% lack health insurance. And this bill risks creating additional barriers for those children, not only for the 107,000 undocumented children under age 16 who call our state home, but also for the 1 in every 3 children in our state who lives in a mixed status household, and for the 1 million U.S. citizen children in Texas who live with at least one undocumented family member. Regular medical care during childhood lays a foundation for lifelong health, and a lack of access could negatively impact these children's long-term health outcomes. The reality is that when immigrants and their children access health care, all Texans benefit. Regular care prevents severe illness, lowering public health care costs, and keeping children in school and employees at work. As Dr. Ron J. Anderson, the late former president and CEO of Parkland Health and Hospital System in Dallas County, once observed, providing undocumented immigrants with access to health care protects public health by controlling infectious disease, and providing prenatal care to undocumented mothers can reduce infant mortality and other complications while saving thousands of dollars per child in healthcare spending. All children deserve access to the health care they need to reach their potential and live full lives. Therefore, we urge you to protect the health of Texas children and their access to health care by voting against HB 2587. Thank you.
ma'am. The chair calls Heather De La Garza Barone, and you are with the Texas Hospital Association. You're neutral on the bill, is that correct?
That's correct, ma'am.
Okay. You may proceed.
Good evening. My name is Heather De La Garza Barone, Associate General Counsel for Texas Hospital Association, and I'm testifying on behalf of our membership today on HB 2587. Last August, Governor Abbott issued Executive Order GA 46, which ordered HHSC to direct Texas hospitals who provided acute care and participated in Medicaid and CHIP to begin collecting information about persons unlawfully present in the U.S. during the hospital's intake process. HHSC subsequently issued more specific instructions directing Texas hospitals to ask every patient about their citizenship status when they presented to the ER or for inpatient services, and to report certain costs provided to this patient population, broken out between those who are covered by Medicaid and CHIP and those who are not. Texas hospitals had about 2 months or so to update their systems, initiate training, and implement all necessary procedures to ensure compliance with the EO and ensure that implementation of the EO would not disrupt patient care. As of today, hospitals have submitted one set of reporting metrics, as you heard, as required by the EO at the beginning of March. Our main concern with HB 2587 is that it does not mirror the processes that hospitals have already implemented to comply with the EO, and we would respectfully request that if the legislature intends to pass legislation on this issue, that they pass legislation that maintains the status quo to minimize disruption to already implemented processes. In addition, as was stated, we would like the legislation to affirmatively state that we are not required to verify patients' answers, and then due to the threat of potential security concerns among hospitals that treat a high number of undocumented persons, we would respectfully request that individual hospitals' reports not be exempt from public information disclosure, so they will not be targeted. We have visited with Representative Olcott and want to express our appreciation to him and his staff in allowing hospitals to be a part of this important discussion. And I'm happy. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Any questions, members? Representative Jones?
What are you confused about? You want clarification on what?
Yeah, so the current draft of HB 2587 talks about tracking uncompensated care, and that's not what we're currently reporting today. What we're reporting is just pure costs. It's not offset by revenues that we get. Uncompensated care in the hospital world is fairly complex, and I'll admit I'm not the foremost expert on it. And so our request would just be to keep what we're doing now, which is reporting the metrics that are required to be reported by HHSC and revising the legislation so it accounts for that.
So what's being asked of in this bill is not what's already being done.
Correct.
It's not merely your immigration status and a statement affirming that you won't be denied health care.
So we are asking the question, and we are providing the statement, and then we are supposed to report to HHSC numbers of visits on the ED and number of inpatient discharges, and then we're supposed to report the costs for the ED for Medicaid and CHIP, and then non-Medicaid and CHIP, and then we have to do that on the same side for inpatient discharges. And so that's not uncompensated care. Uncompensated care would be offset by revenues and payments received.
That's way more complicated than I want to talk about right now. Can somebody come to my office?
I think you and me both, Representative Jones.
Thank you. Appreciate you.
Representative Frank?
Thank you. Thank you very much for your testimony. Remind me who you represent. I'm sorry.
Texas Hospital Association.
Texas Hospital. Okay.
Yes.
So what information is in the bill that is not being currently done?
So it's uncompensated care. So what we're doing is just total costs. And so there's no specific instructions from the agency on how to calculate that, so it's a bit flexible for hospitals on how they're going to calculate that. Uncompensated care, by definition, and by, I think, what is defined here in the bill, would be offset by revenues, and we're not doing that right now. So it's just pure cost.
Okay, so right now you're just saying, here's the patients and
Here's how
I mean,
much it's
obviously
costing.
not delineated down to the patient.
Right.
Here are the services that were
Right.
provided and the cost associated with. What are you using for cost?
It
Using
can vary.
Cost or using?
It can vary. It can
revenue
vary across
somewhere?
hospital. I don't have a specific, like the majority. I think it's a simplified cost to charge ratio. I'd have to verify with our members, but I think that's probably like a general.
Because is that, I mean, I would just think some consistency. That's why I
Sure.
was just curious what
Sure.
was different in the bill versus what's already been promulgated by the agency.
The only instruction we have gotten from the agency is that it's not be offset by revenues. And so, to the extent there can be clarity there, obviously we would welcome that discussion.
Okay. Is there any other clarity that would be helpful from a hospital standpoint if we're going to put something in statute?
The definition of hospital, to be completely forthright. We
No, that's
prevented
good.
language to Representative Olcott to make sure that everybody understands what hospital is. At the very beginning, when the EO was issued, there was a concern that it was just public hospitals, and so public hospitals in our world is public hospitals are hospitals owned and operated by the state or
If it's a mental health hospital, is
right?
that how far down
Right.
does it go?
Right. So we wanted to be very clear on making sure that everybody understands who's required to report and who's required to ask these questions. So that's one of the pieces of clarity we would have. And then in addition to the not having to verify, our employees are not immigration officials. They don't
Right,
know.
yeah, there may be some need
Yeah.
for
Yeah.
some almost protection or clarification in it. So,
Right.
Okay, thank you very much.
You're welcome.
Representative Schaffner?
Back to the cost, is it the cost that you would charge the patient or would charge the insurance company or would charge?
It's the cost to provide the care to the patients. The cost of the hospital to provide the care.
So that would just be, so it wouldn't be any sort of additional on top of that, whether it's facilities fees or,
It would be our costs. So whatever it costs us to provide the care is what we are reporting,
okay, thank you.
based on the coverage. So if it's Medicaid, INSHIP, and then private pay.
Okay, and then the uncompensated care, so you're just doing the actual numbers, but Medicaid will pay for some. of that
Only in
care.
emergencies, situations.
So Medicaid pays for just emergencies, and what about Medicare?
I don't believe so.
At all, okay.
Yeah.
So Medicaid would pay for just if there were emergencies. Does that include just walking in the emergency room or actual emergencies?
I think it's an emergency, has to be certified by the physician. I'm not sure if it's just walking into the emergency room. There is a form that has to be submitted when you're seeking coverage for emergency Medicaid. And, okay, yes, HHSC can probably answer that better than I can.
Thank you.
Hi, I'm Victoria Grady. I'm the Director of Provider Finance for the Health and Human Services Commission. I'm here as a resource on the bill, and I'm happy to answer any questions you have.
Okay.
Go. So, through the Medicaid and CHIP program, there are clients who are covered certain services that would be covered in the hospital setting, and Medicaid has a reimbursement rate for those. Those payments typically do not cover the full cost of care. There's also circumstances in which Medicaid would not cover the care. It's not specific necessarily to emergency department versus inpatient when Medicaid would pay in those circumstances. And so an example would be if there was, for example, a birth and the individual would have emergency Medicaid coverage at the time of the birth, and therefore that's likely to be an inpatient stay. There may also be circumstances in which there's emergency coverage and it is only emergency room or outpatient treatment.
But the physician is the one that determines whether it's an emergency or not. Is that correct?
There's some billing guidelines related to it, but yes, the treating physician is who determines what the CPT codes are that are selected.
And the EO, did that state all hospitals? What was the hospital definition for that?
The executive order used the term acute care hospital, which is not a definition that's found in existing statute. So we've understood that to not include our behavioral health hospitals in the state, the psychiatric hospitals, but to be inclusive of all other general and specialty hospitals.
Does that include clinics and things like that?
It does not. We have exclusively understood that term to be inclusive of the general and specialty hospitals that are licensed as hospitals.
Okay, great, thank you.
Thank you, Representative Pearson.
Thank you, Chairwoman. My question is for Ms. Smith or Lugo. Do you believe that the citizens of the state of Texas have a right to know where their tax dollars are going in this instance?
Do you want to take that first?
Sure. Yeah, so I think with the order that's in place right now, Texans aren't actually getting accurate data on where tax dollars are going because, as has been mentioned, total cost is mentioned, but it's not taken into account when someone is paying out of pocket for their own care. It's not taken into account when Medicaid is picking up part of the bill. So I don't think that's the data that's being collected right now.
So Medicaid is also tax dollars, so would you be supportive of that being reported as a part of whatever total comes out on all this?
Well, again, I think one thing to note here is that even undocumented immigrants in Texas are paying federal taxes that are helping support programs like Medicaid and other programs like Social Security that they themselves are not eligible for. So again, I think if we're going to look at the costs of providing care to undocumented people who may not be paying out of pocket, it may also be important to look at the contributions that they're making to those same programs. And again, I think the concern here is, a balancing of equities and needs, I suppose, of, at hospitals. I think the primary purpose is to provide care for people. And here in Texas, we have people of all statuses living alongside each other, often even in the same families. And so I think we have to balance, a need for transparency in finances with the right of citizen children to access care regardless of, who their parents are or the status of other members of their family.
I agree. I think the transparency here is what's in question. So what I'm trying to understand is you're not opposed to how much money that is going to the care for illegals in the state. You're just opposed to how they come up with the number.
Well, let me clarify that. I think I am opposed to this bill of asking for information about immigration status in a medical setting, because I don't think that there's going to be a way to do that without deterring people from seeking care when they need it. And I think at the end of the day, it's more important for everyone to get the care that they need, especially in emergencies, than it is to track information about what the immigration status is of people when they seek care.
I've worked in a level 1 trauma hospital, and we do know who's here legally and who isn't because of the intake forms. So if we do have that information, you would still be opposed to it, even though it's transparency, and we should have a right to know what money is being spent on illegals in the state.
My concern is more about having a question on an intake form that requires someone to identify themselves by immigration status when they're seeking care. I think, in many cases, this could deter someone from seeking the care that they need because of fear about what could happen to that information once it's disclosed. Where does it go? There's no positive duty to disclose that information to ICE, but neither is there any guarantee that it couldn't happen. And it may even just be someone, acting individually in that setting who, there's no way to guarantee what happens to that information once it's provided.
So the form aside, well, no, let's include the form. Let's just say there is something that identifies whether you're here legally or not. You would be opposed to the citizens of the state of being aware of where those tax dollars are going. The citizens of Texas don't have a right to know if or how much the tax dollars are being spent on illegals in the state.
Again, I think this is an issue that is much more about providing care for all Texans, and I think the right to health care is a really fundamental right, especially for kids. If they miss out on Preventative care, regular access to a doctor at critical stages in their development. This is something that can really have lifelong impacts and even intergenerational impacts. So when I think about the rights of Texans to have their tax dollars used well, I think it's much more cost effective in the long run to maximize access to health care for as many people as possible, regardless of their immigration status, than it is to track the number of people who are accessing care by status.
But you do understand the purpose of the bill is to identify how much of our tax dollars is going towards people who are unlawfully in the state.
I do understand that, but I don't believe that the bill, as it's currently written, effectively accomplishes that goal. Because as I mentioned, I don't think it takes into account the financial contributions of undocumented immigrants to the state. In 2022 alone, they contributed, I believe it was $5.4 billion in local and state taxes alone. And that's not even counting their contributions through payroll using I-10s for federal programs like Medicaid and Social Security.
So you talk about contributions, but you don't want us to know how much we're spending on healthcare.
What I'm saying is, I don't think that gathering information about the status of people accessing care at hospitals is actually giving a full and accurate picture of the cost of providing care to them. As I mentioned, many people, regardless of status, are paying at least partly out of pocket when they seek care. That's nothing that's being kind of subtracted from the numbers that are currently being reported under the order. And I think, again, in this case, the bill is looking at uncompensated care, that's true, but it's still not taking into account the ways that the immigrant community is helping to fund our public health system.
Okay, thank you.
Thank you.
Thank you, Representative Collier.
Thank you, Madam Chair. My question for HHSC, what do you do with the information once you get it? You just collect it and then post it, and then what?
So under the bill, we'd be required to aggregate it into an annual report and submit that report, and that's what we would do with it. There's a similar reporting requirement under the executive order.
Who under the bill? Who are you supposed to submit it to?
We are required to submit the report. Hold on, I'll find it on my pages. To the governor and the legislature.
To the governor and the legislature. And it's just numbers, just data, no names.
Correct.
Okay. And then my question for Texas Hospital Association: when someone is taken to the hospital in an ambulance, are they filling out intake forms?
So under EMTALA, our first and foremost priority is to evaluate and treat and stabilize patients' emergency medical conditions. Typically, when you come into the ER, you're not automatically filling out forms. Typically, at least in my personal experience, it's usually happening towards the end of your visit, or towards discharge, or maybe potentially if you're going to be admitted for observation or inpatient status. So it's not something that anybody's filling out forms as they're arriving to the ED.
Okay.
Generally.
And then you mentioned some things that would be helpful if they were added to the bill. I don't know if you said that or Ms. Smith said that, said about this information will not be shared with anyone else. Like it won't be shared with, like your name will not be shared with any other entity.
So I think what she was what the other testifier was referring to was that in Florida's legislation, and I believe their executive order as well, because I think they started off with a similar process that we have. Their law specifically states that information will not be shared with federal immigration authorities, and I think they're supposed to tell them that. I'd have to verify, but I think that's what she was referring to.
And that's not in this bill?
No, it's not in our EO either.
It's not in the emergency order either. Have you been tracking any data? I mean, I don't even know how you would be able to tell if somebody is not getting treatment.
I don't, I mean,
Like if your hospital stays?
well, we're supposed to report the costs, so to the extent that,
Oh.
of this treatment. And so, again, it's with the number of visits, and then the costs associated with that care, broken up between Medicaid and CHIP, and then non-Medicaid and CHIP. So to the extent we have to follow the patient as they're in the hospital, that is all tracked and recorded in order for us to appropriately report.
But is that apples to apples? I mean, I heard you talking about there's certain things, like if an insurance company, Medicaid, you bill them $300 and they say, oh, we're only going to pay $100.
That's not what we're reporting. We're just reporting pure costs. It's not being offset. In other words, it's not being, the amount that we're getting paid in for that care is not being subtracted by the amounts we're required to report.
Okay. And there's nowhere to put clarifying information in there. It's just, I mean, is that going to be accurate data or accurate information if you're just putting?
I think if they were trying to find out how much, it depends on what you're trying to find out. So if you're just trying to find out total costs without revenue offsets, then that's what you would want. If you want to find out what is being offset by revenues, you would ask for that information. So it just depends on what the goals are.
That is a very important distinction. I appreciate you bringing that up and sharing that with us. Because, here's another thing. I would want to know if a healthcare provider bills or charges one and then the health insurance doesn't pay it, don't we have a right to know? Because then if they're not getting full care or full payment, there's other things that we should have a right to know. And it's just so hard to try to persuade someone or anyone who have a fundamental disagreement with what you feel is right and what they feel is right. It's very hard. I can say this: if somebody has measles, I don't care where they're from. I want them to get help. I want them to go to the hospital, go to the doctor to get help, because we're in a public health crisis when it comes to measles. And if someone is dissuaded or they're unlikely to get health care treatment because they're going to be asked their status, then we're not doing the right thing with public health. And let's just try to break it down into, because when you talk about philosophical things, it resonates with me, but not with everybody else. So maybe we've got to talk in numbers, like this is going to cost more money, or find some way to connect with the people that you are in front of that makes it so that they know it impacts them too. Like, this is something that is going to impact you. And if somebody is not going to get health care because you're going to ask them one question, then let's rethink it. Let's think about this. What do we need to do? How else can you get this information? And what are you going to do with it? I don't know what they're going to do. I mean, they're going to send a bill to the federal government, and is Trump going to pay it? I don't know. I'm just trying to figure out what we're trying to do here. So thank you for being here and sharing your experiences, and I really do appreciate hearing from the healthcare providers. You shared a story about your sister as a doctor, so thank you.
Representative Simmons?
Thank you, Chair. Thank you guys for being here. So I guess I'm trying to get some clarification on the actual language and how that could be interpreted. So when we say lawfully present, does that include like women that are here with, under the Violence Against Women Act? Would that be reported as an undocumented person receiving health care? Is this a person, it's a silly example, but you're here on a vacation and you break your leg and you overstay your visa or something and you go get care? Is that considered undocumented care? And I know those are, anecdotal situations, but just for clarity's sake, how would that be interpreted in your opinion?
Sure. So in the bill, it's very specific to have language that describes that it is a person who has not been lawfully admitted. And so for those persons who are here with some sort of a visa or under some sort of asylum status or something like that, that does not necessarily implicate those persons, because those persons would be lawfully admitted.
And so they're lawfully admitted, they're here, they're still seeking care, and they don't pay for it. What is, I guess, the difference if they're not a permanent, like, how does that differ from them being a permanent citizen, them here being lawful? Like, the care is still not paid for though, right? Because that's the concern, is that we have to pay these healthcare costs.
So in the bill as filed, it does have language about reporting uncompensated care costs. It's my understanding that the intent is to more closely mirror the executive order. The executive order is not specific to uncompensated costs, it's just total cost.
Thank you.
I can maybe add a little bit of context to that, Representative Simmons, if you don't mind. So yes, I think the key also issue with this is that it's lawful admittance and not necessarily lawful presence. So there are individuals who currently have lawful presence who were maybe granted humanitarian parole, TPS, DACA recipients, et cetera, who now have lawful presence and are, if they get asked this question, one, it poses some confusion because they may think that they were lawfully admitted because now they have some form of status, but that is not necessarily true in regards to what the reporting is asking for.
I'm confused. I'm not an immigration attorney, so I'm like, yeah,
Yes,
help me
and,
out.
And I do have some of our friends back here are attorneys, and they can definitely answer maybe some of these questions a little bit better. But I just want to provide that insight that it is a very complicated distinction right now of what is being asked for in both the bill and the executive order.
Okay, members, other questions? Okay, thank you for your testimony. Chair calls Daniel Woodward, Lynn Cowles, and David Chickan. I'll let you. Show Daniel Woodward, Texas Civil Rights Project, and you are against the bill, is that